Okay, welcome back. So we're talking about the immune system, Chapter 2, Week 2. We're going to cover some specific ways in which the immune system works in response to general types of infection, inflammation, with acute changes and then chronic changes, and then how that applies to specific diseases. So our immune systems are a combination of innate immunity and adaptive immunity. The innate immune system is immediate, it's accelerated, it responds to multiple threats. So that could be environmental toxins or pollens, it could be an infection, it could be trauma, like just breaking of the skin, where you lose your protective barrier. And it's non-specific, so your body just sends a rush of all of these cells and fluid and blood flow to address the issue. Your adaptive immune system, that's where you develop the antigen-antibody response in response to a foreign bacteria or virus, etc. And that process takes longer, of course, to develop that memory. So again, your body's under constant threat from microbes, fungi, things that are in the air, in your environment, infectious diseases, or within the body, you can have the threat of cancer cells or cells mutating that your body may address before it ever becomes anything. And beyond the cells of the immune system, we have these first lines of defense, protective physical and chemical barriers. So the skin, obviously it keeps everything intact, right? You've got all the tissues and blood vessels and things underneath the skin. So the skin is a physical barrier that keeps things intact. But also on your skin, you have your microbiome, so healthy bacteria, and those play a role in keeping balance. Your mucous membranes from your mouth, oropharynx, all the way through your intestinal tract, add a line of defense. You've got stomach acid that can kill potential bacteria. You have cilia in the nares and through your respiratory tract that move any inhaled foreign substances like pollens or bacteria or viruses that are inhaled. So those things can trap those foreign substances at the site. And then we have our inflammatory response. So again, acute and chronic phases. And if you look in your textbook at the cells of the immune system, that's on table 2-1. Part of that innate immune system, you've got neutrophils, basophils, eosinophils, monos, macrophages, mast, and dendritic cells. So we'll work with these a little bit. We'll maybe look at some CBCs and try to do some interpretation of that. But these initial cells in the acute phase, part of the innate immune system, rush to the site. And again, it could be infection or an inflammatory process without infection. Think of skin burns or a cut. And you have these cellular messengers, they rush to the site. You've got phagocytic activity that engulf any foreign substances. Neutrophils release reactive oxygen species that degrades bacterial walls, so that helps target and start to kill bacterial invasion. Basophils and eosinophils are important with allergic reactions. So those would be elevated if your patient's having an acute allergy. Basophils specifically release histamine, which is important in the immune inflammatory response. And the eosinophils are phagocytic, so engulfing substances that are foreign, specific to allergies. And you'll see in the textbook there are other cells involved in that initial response. That initial inflammatory response is the same no matter if you get stung by a bee, a cut or trauma, or allergies or an infection. So there's not memory cells involved. It's just all of the messengers rush to the site. And you have really an on and off switches. You don't want an overzealous response. An example of an overzealous response or a response that doesn't turn off would be keloid scar formation, where your body continues to make tissue to heal when that process, should have ended. And you can move into a chronic inflammatory response. So again, where the immune system doesn't know when to shut off, and patients can develop things like chronic bronchitis that just doesn't clear. Bronchitis is an inflammatory process that can go on for weeks, months, or years in response to some initial infection that's already healed. So there's also a vascular response going on anytime you have infection, inflammation, or some foreign substance. And mast cells come to the area and release histamine. Histamine stimulates increased blood flow to the area and also fluid flowing into the area. And the purpose of that is to remove the substance, to help the flow of toxins, or let's go back to allergies, pollen. It'll increase blood flow so that all of those chemical and inflammatory mediators can come and clean up the site. There's a bunch of other chemical activities or chemical mediators that come from those mast cells. So histamine we talked about, proteoglycans, which are important in heparin and chondroitin. So the heparin activity anticoagulant, which can promote new blood vessel growth. Chondroitin sulfate affects your kinin pathway, and that's key for causing vasodilation, and it works with prostaglandin, so that's important in that initial phase. Prostaglandin may be something you're familiar with. We have medications that are prostaglandins, but this is synthesized in the body. So can cause pain, but important in bronchoconstriction, increased vascular permeability, and inhibiting platelet aggregation. So all of that's important during that initial phase in that inflammatory response. So stepwise, imagine you have a cut, a deep cut at the skin level, and maybe some bleeding there. So step one is that you've got these cells, these white cells, which are always in surveillance, always floating around. They come to the area, they recognize that a trauma has happened. And then your mast cells are going to release histamine and some other chemical mediators that will help increase vasodilation and increase blood flow and fluid to the site. Anytime there's trauma or an injury, that area where your blood vessels are, they'll dilate and allow these cells and chemical mediators to cross into the tissue more easily. So you've got then fluid, you've got all your blood clotting factors, neutrophils, monocytes. They'll move from the capillaries into that damaged tissue area. And then cytokine release, which is one of those chemicals, will attract phagocytic cells. Those phagocytic cells then come and engulf either bacterial infiltration or maybe it's pollen or some sort of foreign substance, or they'll engulf dead cells and debris from your immune response. Lymphatic drainage improves to remove any dissolved toxins or remnants, dead tissue from the battle. And then finally, neutrophils and monocytes become macrophagic, and they'll engulf any foreign substances. And generally speaking, in healthy individuals, that acute inflammatory phase should resolve itself. Things should start to heal. And usually it doesn't progress into something worse. But for some people, if that initial immune response is not effective, or you have complications, just overwhelming bacterial invasion, and that can happen in the setting of maybe someone with chronic inflammation, chronic stress, for whatever reason their immune system is not as robust, then you can flip into this chronic response, chronic phase in this inflammatory process, and that can go for weeks or months. Adaptive immunity is an individualized response, and it's specific. It's based on memory cells. So any antigen or foreign substance that makes it past that initial defense will then be attacked through your adaptive immune system. And this is going to vary person to person based on what exposures we've had, what environments we've lived in, and what immunizations we've received from childhood till now. We have two types of adaptive immunity, cellular immunity and humoral immunity. Cellular immunity involves your T cells. They're called that because they mature in the thymus. And T cells are key fighters in the adaptive immune system. Of course, your white blood cells are constantly monitoring for threats, but once an intruder is detected, your adaptive immune system builds a customized defense to fight it. So each T cell is unique. It's designed to fight a specific type or only one type of intruder. And then once they're defeated, those T cells copy themselves, so they replicate and join the fight. And then some of them can convert into memory cells. So you have that long-term memory. If you are exposed to a particular virus, again, you already have a specific defense created for that. B cells are made in the bone marrow, or that's where they mature. And they can differentiate into memory cells or plasma cells. And that's who's producing those immunoglobulins, which is important for antigen antibody recognition. They're critical for acquired immunity, which is that actively engaging with the antigens, either through invasion or vaccination. And protection is usually long-term. So what is the difference between these T cells and B cells? T cells protect you from infection or exposure to cancer. So again, you're constantly exposed to potential pathogens. The T cells have the ability to come and kill and wipe out infected or cancerous cells. And then they direct the immune system or the immune response by helping B lymphocytes come to the area. They can mark cells for destruction, antibody creation, etc. So really, you wouldn't survive without your T cells if that invasion or infection gets past your broad, non-specific inflammatory response. Your B cells, then, they're creating antibodies. The antibodies, they bind to pathogens or the foreign substance. For example, an antibody can bind to a virus, which prevents it then from entering a normal cell and replicating. And then B cells can also recruit other cells to come help and help engulf problem invasion. So the B cells, they create immunoglobulins or antibodies. So we can use that term interchangeably. And you'd be familiar with the different types of immunoglobulins: IgG, IgM, IgA, IgE, and IgD. There's another table in your book that goes through these, but when we're looking at infections, we can tell if that infection is recent or old based on how much IgM or IgG you might have. IgM is first formed in response to that antigen. IgG is a second response. The great thing about IgG is that it can cross the placenta to protect the fetus. So any infections or exposure mom's had through immunizations, that she can give passive immunity to the fetus. So if you had a patient that was presenting with an infection, of course, your first response would be to get a CBC, a complete blood cell count with that white blood cell differential, and that'll point you in some direction. You'll see, are there a lot of, first of all, is the total white blood cell count up? So there is some infectious or immune response happening. And then which cells are there more of? And then you could look even further by looking at specific immunoglobulins or antibodies. But the best way to grow your immune system is to actually get an infection or have an exposure, whether you develop symptoms or not. But that can be risky with certain things. If you think about the childhood illnesses like measles, mumps, rubella, pertussis, you can also have significant morbidity, even death, childhood measles and things like that. And so vaccines were developed to stimulate the immune system and provide protection without the consequences of getting a full-blown infection. So vaccine response, it's influenced by a couple of different things: the antigen characteristics and the dose, how it's given, the route. So it could be live oral dose, or it could be IM or sub-Q injection. And then what adjuvants are added to enhance that immune response. And some of the things that they add to vaccines are aluminum-based material or oil emulsions that kind of accelerate your immune response. And of course, those adjuvants, those additives are really those things that patients and the community are concerned about or leery about putting into their bodies, right? So as healthcare providers, that's something that we have to learn about and be able to troubleshoot with different families. The active ingredient in vaccines that we're looking for is the antigen. And that antigen is what's going to stimulate your adaptive immune response. And that comes in different forms. It can be little pieces of DNA or RNA. It can be the protein or a sugar molecule from that antigen. It can be whole organism, or it can be just particles of the virus or bacterium in a weakened form. And it can be live or inactivated. So live vaccines give a really robust response that's almost identical to whether you had the actual infection. Examples of this: German measles, mumps, typhoid. There's a live vaccine rotavirus that we give in the PEDS clinical setting. We generally do not give measles and mumps live anymore. It would be very difficult to find access to that. And the problem with these live vaccines, they're very good at developing this immune system response, but they can also, rare, but they can also develop an infection. So we have to be really careful about giving these around family members or in an inpatient unit where you might have immunocompromised patients or people that are adjacent to the person receiving the live vaccine. Inactivated vaccines are made from fractions or whole parts of viruses or bacterial antigens. And it's such a small fragment, it's inactivated. And so you're not at risk of developing signs and symptoms of the disease, but the memory is not quite as robust as if you had the active infection. And then recombinant vaccines are developed through genetic engineering technology. And some examples of that are the Hep B vaccine, HPV, and some of the influenza strains. And then the Johnson & Johnson COVID vaccine was also recombinant. Okay, so that was a really, really brief review of the normal function of the immune system. There's a lot more in your textbook that you can read about in terms of that. Now we're going to shift into an altered immune response and the pathology that can happen with the immune system. So a malfunction can happen at any point within your immune response. So it can be an exaggerated or hypersensitivity response. It can be failure of self-recognition, and that's what causes autoimmune disorders, or diminution, which is your immunodeficiency disorders. And those can be genetic or acquired. So you can be born with immunodeficiency, or it can occur as a result of failure of your immune system. Hypersensitivity is an inappropriate response or an overreactive response to an antigen. And the result is inflammation and destruction of healthy tissue. Hypersensitivity reactions can be immediate or delayed, occurring minutes to hours after re-exposure to that antigen. And they are categorized into different types. So we have type 1 IgE mediated hypersensitivity, and that originates with your B lymphocytes, IgE and your mast cells and basophils. This is where you have that histamine reaction. Examples are allergic rhinitis or asthma or any kind of allergic anaphylaxis. Type 2 is cytotoxic. That's also with your B lymphocytes. That involves IgG and IgM. Mediators involved are complement. And this is where you see blood transfusion reactions or blood type disease or hemolytic disease of the newborn. Type 3 is immune complex, again with the B lymphocytes. IgG is involved. And here we have examples: serum sickness, systemic lupus, rheumatic fever, or rheumatoid arthritis. And then type 4 is cellular. That involves your T lymphocytes. Cytokine release is involved. And examples of that are contact dermatitis and Crohn's disease. And the types of antigens involved in hypersensitivity, so they can be autoimmune, self-antigen, like with lupus. They can be another person's antigen, alloimmune, and that's where we see that blood transfusion reaction, or environmental allergens. So with type 1, it's IgE antibody produced instead of IgA or IgG. Mast cells are sensitive to the allergen, and then you can have anaphylaxis. The treatment goal here is suppression of that inflammatory activity or cascade. So let's say you had a bad allergic reaction. We're going to give you medications that will suppress the immune system. 2, cytotoxic. So here we have destruction of antigens on the target cells or tissues, resulting in destroyed or malfunctioning cells. So one of the examples was hemolytic disease of the newborn. So this is a disorder where the baby's blood type is different from the mother's blood type, and exposure of that during childbirth causes an antigen-antibody reaction or overreaction, and then destruction of the baby's own red blood cells until there's some resolution. Prevention is the best form of treatment here. So when we have women with blood type incompatibilities, or let's say Rh negative, there is a medication that we can give the mother to suppress that immune system overreaction in the fetus. Type 3, you have circulating antigen-antibody complexes that have not been cleared by your innate immune cells. So these accumulate and become deposited in the tissues, and that's where they can cause tissue damage, and often affects kidneys, joints, skin, and sometimes glands. So there's like autoimmune thyroid disorder, autoimmune pancreas, right, diabetes, type 1, and other examples. So treatment for this is disease specific, meaning it's targeted specifically at the organ or system that's being attacked. Type 4 involves a delayed processing or delayed response of the antigen by macrophages. Once processed, that antigen is presented to the T cells, usually helper or cytotoxic T cells, and that results in cytokine release, which causes inflammation and antigen destruction. This is not antibody mediated. So examples of this: TB skin testing, where you get an overreaction at the site, or contact dermatitis from something like poison ivy. So delayed response, not involving memory cells. Alloimmunity is an immune response to non-self antigens from members of the same species. So there's different types: allogenic, syngeneic, autologous, and xenogenic. And this is in response to tissue transplants or organ transplants. So essential to have as close a tissue match as possible to prevent rejection. And then when we do see rejection reactions, there are hyperacute, acute, and chronic, and then host versus graft rejection. Key here is going to be prevention. So that includes finding a close match and then initiating immunosuppressive therapy before the transplant. We do that with corticosteroids usually. The transplant patient then requires immunosuppressive therapy for life so that they don't reject the donor organ. Once a rejection is suspected, immunosuppression therapy is intensified to try to reverse it. In autoimmune diseases, your body's normal defenses become self-destructive. They fail to identify self-antigens from non-self foreign antigens. Central tolerance happens in primary lymphoid tissues where those lymphocytes are maturing. So in the thymus and in the bone marrow, before those cells are completely mature. Those cells that bind to self, your B and T cells, are destroyed or suppressed. And that's central tolerance. Those cells are destroyed. Peripheral tolerance happens with those B and T cells at the secondary lymphoid site where they migrate to, and that can happen in the lymph nodes or the spleen. And when peripheral tolerance is happening, those autoreactive cells are ignored or destroyed. So it's the location of where that's happening. So with autoimmune diseases, you have problems with tolerance, sequestration, and the regulatory mechanisms that shut things down. usually an autoimmune disease, it's a combination of environmental and genetic factors. So usually there's genetic predisposition, or it runs in families. And then there has to be some sort of trigger, whether that's environmental, say exposure to radiation or something like that, or it could be a viral illness that triggers it. So it's always a combination of that, viral plus genetic predisposition. There may also be some hormonal links. Autoimmune diseases are much, much higher in women, and so they think that there's some hormonal connection there. And autoimmune diseases can affect either just a specific tissue or organ, like with autoimmune thyroid disease, Hashimoto's, or multiple systems, like with rheumatoid arthritis, where it affects all the joints in your body. There are two different methods that the immune system attacks itself through autoimmune disorders. And autoimmune disorders are characterized by exacerbation and remission. So exacerbation, meaning you have a flare-up, you're having a lot of symptomatology, things are getting worse. And then periods of remission where things calm down with or without treatment, and symptoms are improved. Autoimmune diseases are generally lifelong. Even think of things like asthma or eczema. You'll have flare-ups, you'll have times when things get better. We generally have patients keep records of things that improve symptoms, things that make things worse. There can be hormonal fluctuations, there could be emotional stressors or physical stressors that make things worse. And then because there's a range of symptoms and they can vary so much with different patients, it's very hard to diagnose. And you can also come in with really generalized symptoms of being, for example, thyroid disorders. You can come in with fatigue and not sleeping well and achiness. So very broad, non-specific symptoms, hard to pinpoint, hard to target. And that's one of the challenges of diagnosis. We're going to look at a couple of specific disorders of the immune system. So systemic lupus, it's a chronic inflammatory autoimmune disorder that affects the connective tissue. So as you recall, your connective tissue surrounds muscle cells, connects tendons that attach muscles to bones, and supports the skeleton. Also found in other places like in the eye, around the cornea. So that connective tissue provides some structure and function throughout the body. This disorder occurs more often in women than men. The female to male ratio is anywhere from 7:1 to 15:1. And it's more common in Asians, Blacks, and Hispanics compared to whites. Researchers have found that these patients can have genetic alterations, so susceptibility gene, and then an absence of protective genes against the disorder. In lupus, B cells are thought to be activated, and autoantibodies bind with autoantigens and form these immune complexes. The immune complexes fight against your body's own tissues, fight against nucleic acids, red blood cells, platelets, and lymphocytes. And then hyperreactive helper Ts and subdued suppressor Ts create a prime environment for those B cells to overproduce. So the symptoms are occurring throughout the body. Most often affects the heart, your joints, skin, lungs, blood vessels, liver, kidneys, and nervous system. So a wide range of symptoms these patients are coming in with. And here you have a list of those symptoms. Disease onset is anywhere between 16 and 55. So, you know, if you had a patient that came in with a wide range of different symptoms, you'd want to rule out, you know, if they're having heart problems, you want to rule that out with an echo or an EKG, go after the most serious and potentially highly consequential types of things, rule those things out. But you would do blood work and you can look for antibodies and autoantibodies. So again, difficult to diagnose. Clinical manifestations vary and can be age-based. You know, the manifestations can be skin rashes, you can have sores, joint pain, and then more seriously, with your white blood cell lines, these patients can have leukopenia, lymphocytopenia, thrombocytopenia. So if they're having low white blood cell counts and not able to replenish, they're going to be at risk for infections. They can have neurologic disorder with brain irritation, headaches, seizures, things like that. So your treatment is going to be a lot of symptom management. And then really we worry about our autoimmune patients or any patients with chronic disease about being in a chronically inflamed or inflammatory state, which is suppressing the immune system or altering the function. So you want stress reduction strategies to minimize inflammation, exercise, sleep, healthy diet, all of those non-pharmacologic interventions that you can bring. Shift gears into immunodeficiency. So that's defined as a diminished or absent immune response, which increases your susceptibility to infections primarily, or cancers. But usually if your immune system's not functioning, infection is going to be, can be severe and deadly. So there's two types, primary or secondary. Primary reflects a defect with your immune system, and secondary is from an underlying disease or something else that's suppressing that immune system. So primary immunodeficiency, usually genetic or congenital abnormalities. And then secondary immunodeficiency is a loss of immune function from a cause which could be infection like HIV, but could also be from severe malnutrition, liver disease, or not having a spleen, or could be from drug therapy or just severe chronic stress. We have acute and chronic, and most commonly kicked off by viral infection. Again, like things like HIV, although there are secondary immune system disorders like leukemia, multiple myeloma, and viral hepatitis. The primary immunodeficiency, that's that genetic or congenital abnormality. There are hundreds of these disorders. We do test for the most common ones, or more common ones, I should say, with the state newborn screening that every state does at birth. But there are so many disorders, we couldn't possibly test for all of them. So here you have defective receptor cells, a deficient complement system, and then deficient or defective adaptive systems. Disorders are quite rare, but we do see them in the peds world. Clinical manifestations, these kids show up with multiple infections, and the types of infections that we see with them, common ones, obviously, kids as they're growing develop a lot of infections from colds and flu, viruses, things like that. These kids get those infections, but they also get rare infections from, we will isolate types of bacteria in their bloodstream or in their lungs that are not really common or that don't commonly cause systemic infection. So kids that are requiring lots of medical treatment or hospitalizations for persistent or recurrent infections, that would be a clue to do a diagnostic workup. So again, we do that newborn screening Here in the slide it says for SCID, that's severe combined immunodeficiency disorder. That's one of the disorders that we look for. And then treatment is really to prevent infection. Sometimes we can give immunoglobulins to help fight illness. We may have these patients on prophylaxis antibiotics to prevent further infections, but really critical to limit outside exposures. Okay, let's look at causes of secondary immunodeficiency. So HIV and AIDS is an example of that. AIDS is a deadly disease, sexually transmitted, caused by HIV, which is a retrovirus. The virus attacks and weakens the immune system. According to the CDC, 38 million people worldwide have HIV, 1.2 million in the US, but 14% don't know that they're infected. Okay, so transmission through intercourse, drug injection, and then vertical transmission from mother to child. So HIV requires a host to survive, and it contains 2 copies of single-stranded RNA, and it's enveloped in a spherical virus. Okay, so most of our pharmacologic agents are targeted towards a specific part of the life cycle of the HIV virus. Once it gains access to the body, the virus targets your macrophages, dendritic cells, your helper T cells. The HIV outer surface has a glycoprotein that binds to CD4 on your dendritic cells. Macrophages are also a target. And the virus needs to bind with a co-receptor known as chemokine receptor, which allows for viral entry. So it attaches to the cell and then injects its contents into the cell. Once it's injected that HIV RNA and converted it to DNA, then the CD4 cell, your host, your cell's nucleus combines with that genetic material. And then when the cell replicates, it transcribes that new data with the HIV virus attached. And then you have replication of HIV within the body. And here's a diagram of that cycle from your book, so you can pause and take a look at that. Once that HIV virus is replicating, it's going to attach to other CD4 cells or your T cells and continue to attach, inject, kill that host cell, and then replicate, spread to other cells. So eventually your T cells get wiped out. So in the beginning stages, people can be asymptomatic or have subtle symptoms. Usually they present or recall flu-like symptoms. If things progress unrecognized, they can get ulcers or sores throughout the body, in the mouth, anus, esophagus. And that stage is called acute retroviral syndrome. That usually happens about 4 weeks after infection. If you do blood counts, you'll see a very high viral load at that point, and this is when the patient has the highest transmission potential. After that initial phase, often symptoms will calm down, which is pretty dangerous because an individual might write that off as just having had the flu and not being aware that they have HIV. And then they can shift into this latency or chronic phase where the virus continues to replicate and the patient either doesn't have symptoms or the symptoms are very soft, subtle, so the patient might not be seeking treatment. And then late stage HIV is called AIDS, acquired immunodeficiency syndrome. And at that point, the patient is very, very sick and high risk for no longer surviving. Life expectancy once AIDS is diagnosed is usually about 3 years, and those patients are at risk for cancer and opportunistic infections. And those opportunistic infections are more common in children. We see yeast infections that won't clear, oral candidiasis, or candida in multiple areas is a common sign of an immunodeficiency disorder. So diagnosis is through testing. Of course, you would have to have a clinical story or clinical picture. Usually these patients come with concerns. Maybe they've had unprotected sex or something that prompts them to come have diagnostic testing done. But you can find out if there's exposure to the virus as early as 2 weeks after that exposure. And there's a couple different tests, antibody or combined antigen antibody, and then viral detection where they actually count the viral load. There's a couple different treatment modalities. Highly active antiretroviral therapy, that's the #1 recommended approach, and usually involves 1 to 3 antiretroviral medications from different classes. And these things act at that transcriptase area, or can be protease inhibitors, which suppresses HIV replication, right? Because if it's not being replicated or carried out, then it can't, the HIV virus itself cannot replicate. Continued exposure to HIV can increase the viral load or introduce the client to another strain. So they want to continue to have safe sex or clean needles and no needle sharing, even if their partner also has HIV. There are 2 prophylactic medications, PrEP and PEP, that you can prescribe to patients if they do engage in high-risk behavior. And how it works is it blocks an enzyme that HIV needs to replicate within your body. So you take it as a preventative. And then you're generally going to want to recommend safe sex practices to your patients. And then working in the healthcare field, we're going to avoid contact with body fluids, use our protective gear, right? Overall, that's it for this chapter. It's important to help our patients develop strong immune systems to prevent diseases in the first place. We do that in infancy and childhood by actually having exposure to the environment. Kids that have exposure to farm animals and multiple pets are less likely to have pet allergens. Getting immunizations, sharing infections within the family, that all builds the child's immune system. And then as an adult, once your immune system is built and robust, you're then at risk for chronic inflammatory states and the diseases that result from that. So we want to engage in activities that promote a healthy immune system and decrease inflammation. Anything that reduces stress, so meditation, prayer, yoga, exercise, things like that. We want to have a healthy diet that's rich in prebiotics and probiotics because they can decrease inflammatory markers in the body. And then routine screening for different health disorders to improve your health. So that's it for chapter 2, and we'll do some case study work in class. Thanks.